Hello students, hope you are all joined the session. Today we are going into the INICET PSM session, a high yield test and discussion. I hope you have all solved the questions. So we had 60 questions. So coming to this class, if you see the INICET exams, so from the previous exams, I have taken the questions. If you see, from the previous exams, from the last 2 or 3 sessions. So what is with INICET is, they have a habit of asking questions repeatedly from the same related topic from the previous exam. So the questions may not be the same, but the topics which were asked in the previous exams are more prone to be repeated next time. So last time, there were 2 sessions on an average, 3 questions from communicable, non-communicable diseases, 3 questions from MCH and family planning, 2 questions from epidemiology, 1 from the concept of health, 2 from health programs, 1 from vaccines, 1 from statistics, and other topics where they touched was emergencies like snake bite or dog bite, any emergency, disaster management. They were very fond of in asking questions like from different subjects they could combine and ask. Then entomology, health education. So these are all the topics which were asked questions in the last exam. So if you see the INICET exam, the patterns are different. It's not like a simple clinical based question asked in NEET. In INICET, you may have multiple patterns. Like first, it can be either true or false, a combination of true or false, or a combination of match the following, or sequential arrangement. Arrange them in the order. So these questions, they will be time consuming. So you have to practice. So more than going on revising again and again the portions, it's better you practice in terms of questions so that your mind will adapt to this multiple pattern of questions. So be aggressive in the exam. In the exam, try to attend at least 150 out of 200. You can go to 180. You have to be aggressive, then only you will get a rank. So rather than sitting at 100 and being on a safer side, it's better to go for aggression. So now when you practice 200 questions in 2 hours, so that in the exam you will be ready for 200 in 3 hours. So whenever you are practicing questions for the INICET, now keep previous year questions you can take. In 2 hours, you practice these 200 questions. So this will help you to solve easily the 300 questions, the 200 questions in 3 hours in the exam. So we'll go to the questions. So the first one, it is of a match the following. So they have given on the left-hand side the various phases of the disease in the natural history of the disease, and in the right-hand side we have the various type of interventions and then the preventions modes there. So we have to match it. So in order to match this, first we should know the natural history of disease. This is an easy question. So now we have, so what are the various phases of the disease? So we have a pre-pathogenesis phase in a disease. Next we have a pathogenesis phase. So what is the pre-pathogenesis phase? In this pre-pathogenesis phase, we have the agent and the host. And the agent and the host, they are brought together with the help of the environment. So before the disease agent enters the man, it is called as pre-pathogenesis phase. So after it enters the man, we come into pathogenesis phase. In this pathogenesis phase, we have early pathogenesis and late pathogenesis. So now we can take TB. So TB, bacilli, Mycobacterium tuberculosis, and then we have man. So the bacilli enters the man. So when the bacilli enters the man, we come into pathogenesis phase. So in the early phase, we start developing symptoms slowly. And in the late pathogenesis phase, we can go for complications. This we can apply primary prevention here. So primary prevention, what are we doing in primary prevention? We are preventing the development of the risk factor to the disease. We are preventing the development of the risk factor to the disease. This is primary prevention. Then, in the disease, if we are doing early diagnosis and treatment, that is secondary prevention. In the disease, if we are doing early diagnosis and treatment, then it is secondary prevention. Then, for complications, we are doing tertiary prevention. Either we are limiting the disability because of like diabetes or any other disease, a man has lost his leg. We are further limiting his disability by giving him some crutch or some walking stick. Then we are giving him a new life by giving him a new artificial limb or a new job, rehabilitation. So disability limitation and rehabilitation come under tertiary prevention. Early diagnosis and treatment are the interventions under the secondary prevention. Under primary prevention, whatever interventions we are possible is health promotion, and then specific protection like vaccination against a particular disease, wearing helmet against RTA, everything comes under primary prevention. Can go here. So pre-pathogenesis phase. In pre-pathogenesis phase, what prevention can be done? Primary prevention. So both disability limitation and rehabilitation come under tertiary prevention. Then early pathogenesis and secondary prevention. So A2, B3, C3, and D1. So A2, B3, C3, D1. So the option B is the right option. A2, B3, C3, and D1. So it is a straightforward, easy question to start with. This is the period of pre-pathogenesis, period of pathogenesis, agent host environment. After the disease occurs, we can do either secondary prevention or tertiary prevention. When there is an interaction of the agent with the host, we can do primary prevention. Under primary prevention, we have health promotion and specific protection. Under secondary prevention, we have early diagnosis and treatment. Under tertiary prevention, we have disability limitation and rehabilitation. Next question. So a study was done to identify the association. So a study was done to identify the association between various categories of hypertension and the presence of LVH. So we are doing a study. We are taking two groups of people. One people are having hypertension plus, some other people are having no hypertension. So hypertension minus. We are seeing the association between hypertension and presence of LVH. What is LVH? Left ventricular hypertrophy. So because of hypertension, there is left ventricular hypertrophy. So LVH plus, LVH minus. So we have two groups of people. Hypertension plus, hypertension minus, and we are seeing them whether they are having LVH plus and LVH minus. In the study, the null hypothesis. So they are doing a study. Before doing every study, they will take something called null hypothesis. They are telling no association exists between different hypertension categories and presence of LVH. So they are taking a null hypothesis. So before doing every study, we take something called null hypothesis. What is the meaning of null hypothesis? That is nothing but, it is nothing but opposite of what we want to prove. So null hypothesis is nothing but opposite of what we want to prove. Suppose if you want to prove a drug A is better than drug B, our null hypothesis will be drug A is not better than drug B. Here in the study, they want to prove there is an association between hypertension. Hypertension causes left ventricular hypertrophy. So they are taking the null hypothesis as opposite of what we want to prove. No association exists between different hypertension categories and presence of LVH. Next, and then what is happening? This null hypothesis was accepted. The null hypothesis was accepted. So they are accepting the null hypothesis, but truly an association does exist. So what I am telling, actually here the null hypothesis is false. What does it mean? So the null hypothesis is false because there is truly an association, but instead of the null hypothesis, irrespective of the null hypothesis being false, it has been accepted. So what is the error in this study? So what is the crux? The reading the question takes time, but the crux is easy. What is the crux here? So null hypothesis is false, but they have accepted the false null hypothesis. What is the type of error? The null hypothesis is false, but they have accepted it. See here, this is the table, null hypothesis. So you can keep null hypothesis like your girlfriend. Just for your understanding, there is nothing possible. Okay, just you can take it like a girlfriend. Okay, your girlfriend is true. Your girlfriend is true, but you are rejecting her. You are rejecting her love. Your girlfriend is true, but you are rejecting her love. Then it is called type 1 error or alpha error. Alpha means what? Male ego. Because of male ego, you are rejecting your girlfriend when she is true. So this is called type 1 error. So what is type 1 error? Rejecting null hypothesis when it is true. So type 1 error, you are rejecting your girlfriend, a true girlfriend. That is called what error? Type 1 error. So rejecting the null hypothesis when it is true, that is called as type 1 error. So your girlfriend is false, you are rejecting her, then there is no problem. Your girlfriend is true, you are accepting her, then there is also no problem. Next, your girlfriend is false girlfriend, but you are accepting her. Your girlfriend is false, but you are accepting her. That means you are accepting the beta, you are accepting the son of someone as your son. So accepting the null hypothesis when it is false, it is called as type 2 error or beta error. You can remember type 2 error or beta. You can remember as beta. Alpha error means it is male ego. Alpha ego means they are called as alpha. Bad ego. Because of bad ego, if you are rejecting the null hypothesis and it is true, it is called alpha error. Then you are accepting it when it is false. Accepting the null hypothesis when it is false, then it is called as type 2 error or beta error. So what we are doing in our study, we are accepting the null hypothesis when it is false. We are accepting the null hypothesis when it is false. Here, we are accepting it when it is false. Since we are accepting the null hypothesis when it is false, it is called as beta error. Since we are accepting the null hypothesis irrespective of it being false, then this is called as, even though it is false, then it is called as the beta error. Accepting the null hypothesis even though it is false. So you can remember based on whatever, you can remember like girlfriend, or if you are feeling, you can remember like boyfriend or anything, whatever you feel, right? You can remember. So it is true, but you are rejecting it because of ego, alpha error. It is false, you are accepting it, irrespective of it being false, it is called type 2 error or beta. Next, another word I want to introduce to you, power of the study. So what is power of the study? Power of the study is nothing but 1 minus beta error. What is power of the study? 1 minus beta error. Now you know what is type 1 error, type 2 error means power of the study is 1 minus beta. So 3 things they can ask in exam. Type 1 error we saw. Next, type 2 error. Third one is power of the study. So type 1 error is nothing but it is an alpha error. Type 2 error is nothing but it is a beta error. Then they will ask something called p-value. What is p-value? It is nothing but it is the probability of type 1 error. So p-value, it is nothing but it is the probability of type 1 error. Probability of type 1 error is the p-value. So these are the things that can be maximum asked from this. So next question is an easy question, direct question. Why is I wanted to introduce to you a new theme of WHO. Every year, WHO celebrates a day remembering its origin. What is the origin of WHO? It is nothing but World Health Day. So what is the day? It is nothing but it is the World Health Day. Every year, WHO celebrates a day remembering its origin. Every year, it is celebrated on April 7. Celebrated on April 7. Every year, they have a theme. What is the theme for the year 2023? The theme for the year 2023 is Health for All. This Health for All. So this is the theme, Health for All. This is the theme for the year 2023. WHO is celebrating its 75th year theme, World Health Day. So the theme for this year is Health for All. Health for All. Simple question. Just to keep you updated. Next, in the community, for a certain disease, there are 10 diagnosed cases for every 100 undiagnosed cases. This phenomenon is shown. See, in the community, so this is what we see. This is the community. There are 10 diagnosed cases for every 100 undiagnosed cases. So undiagnosed cases means they are inapparent. That means they are inapparent. They are carriers or subclinical. Inapparent, carriers, or subclinical. Only 10 cases are clinically apparent. So this phenomenon is known as our Titanic. Have you seen the film Titanic? This is our famous iceberg phenomenon. This is our famous iceberg phenomenon. So majority of the diseases in our community like diabetes, hypertension, cancer, they are submerged below the water level. So we are not able to see it. Only a small part we are seeing it. So this is called as iceberg phenomenon. So what they are asking in the question, simple question, iceberg phenomenon is shown by, that's all. That is the question. One word if you want to make the question, iceberg phenomenon is shown. So for this you should know which are the diseases which do not show iceberg. If you see these three diseases, they do not show iceberg phenomenon. They do not show iceberg phenomenon. So hence, the only disease which shows iceberg phenomenon is poliomyelitis. If you see for poliomyelitis, around for every 100 cases of poliomyelitis, 95 will be inapparent. We cannot tell. So, they will not know they had the disease. They will be cool, jolly. Only in this less than 5 only, they will have some symptoms related to disease. In this also, around only 1% will develop paralysis. Polio paralysis, no, the leg, difficulty in walking and everything. Only less than 1 or 1 only will develop paralysis. 95 will be inapparent. So the disease which shows iceberg phenomenon among all the following is only poliomyelitis. So all others do not show iceberg phenomenon. So what is the mnemonic for the diseases which do not show iceberg phenomenon? It is Rute Mera. What is this? It is Rute Mera. Rute Mera. So these are the diseases which do not show iceberg phenomenon. Rute Mera, it is like a Hindi song. You are mine. Rute Mera. So it's like a Hindi song, you can remember. So rubella, tetanus, measles, rabies. Sometimes with this, we can even add tuberculosis. In case they ask on order from highest to lowest. See, if you see rabies and tetanus, we cannot hide. If you get rabies, you can never hide it. You will start barking like a dog. Then you will have fear of water. That is with rabies. In tetanus, spasm of the muscles. of the mouth rises sarcoidosis like ghost movie, your body will go down spasm, full spasm. Then followed by the measles, maculopapular rash, and then cochlear spot, followed by rubella, followed by pertussis. So these are the diseases which do not show iceberg phenomenon. That is, like they are like the boys' love. If a boy loves a girl, they cannot hide it. If a boy loves a girl, he cannot hide it. So these are the diseases which he cannot hide. They cannot hide. It will come out. They are having disease. So the symptoms or the signs will come out. They cannot hide. But what are the diseases which can hide? Diabetes, hypertension, cancer, malnutrition, poliomyelitis. These diseases, they show iceberg phenomenon. They hide their symptoms and behave like normal. Even COVID-19, someone will be having COVID, but they will be looking normal. Okay. Next, 37-year-old woman comes to PHC with complaints of bleeding per vagina. So she was screened with viability. What is viability? Visual inspection with acetic acid and visual inspection with Lugol's iodine. So what is this viability done for? It is done for cervical cancer detection. Why they are doing this? It is done for cervical cancer detection. So what they are doing? There is a bleeding PV. So they are doing yearly diagnosis. What they are trying to do? They are trying to do yearly diagnosis by doing viability, visual inspection with acetic acid and visual inspection with Lugol's iodine. Using this, they are just checking the area whether there is any change in the cells color. So with this, they are seeing in the microscope. So by this, if it is there, then they may go for colposcopy and they may start treatment for cervical cancer. So this comes under early diagnosis and treatment. So this early diagnosis and treatment, it is an intervention under which prevention? It's an intervention under secondary. So early diagnosis and treatment comes under secondary prevention. So we are doing early diagnosis and treatment under secondary prevention. If you see majority of our national health programs, are coming under secondary prevention. Majority of our national health programs. What we are doing in them, we are mainly doing secondary prevention like NP, CD, CS. Then National Tuberculosis Elimination Program, National Leprosy Eradication Program. Mainly we are doing what? Treatment. Mainly we are focusing on diagnosis and treatment. But some programs like Universal Immunization Program or National Immunization Schedule, that may be primary. We are giving specific protection by vaccine. So these are the various stages. See, so if we want to prevent the development of risk factor itself, then it is called primordial prevention. So what is primordial prevention? Preventing the development of risk factor itself. So we are preventing the development of risk factor. If you prevent the development of risk factor, then it is called primordial prevention. If you are preventing the development of disease from the risk factor, then it is called primary prevention. If you are preventing the development of disease from the risk factor, it is primary prevention. Then, if you are preventing the complications by doing early diagnosis and treatment, then it is comes under secondary. Then we are doing tertiary prevention in the later stages of the disease. Either we can limit the disability. Suppose there is a problem in the knees, further dragging of the knees leads to further complication, that is disability limitation, or we can give him a new life by giving him a new knee or a new job or a new society we can give. That is rehabilitation. Next question. So, here, 30-year-old male, he had an accident. A 30-year-old male man is there. He is having a meeting it with an accident. He's meeting it with an accident. Okay, next. He was bedridden for the next 5 years. So after the accident, he was bedridden till 35. So for the 5 years, he was bedridden. Then he died at the age of it is, I think, 35. He died at the age of 35 years. Then he's died. He died at the age of 35 years. His peers are expected to live up to 75 years. So normally his peers, they will live up to 75 years. But he has died at the age of 35 years. So what is the DALY in this case? So his age now is 30 years. 5 years, it has been lost due to accident. So 5 years, it has been lost due to accident. It is nothing but years of life lived with disability. Years of life lived with disability. He has to live up to 75 years, but he died at 35 years. So 75 minus 35 is loss of 40 years. So years of life lost due to death is 40 years. There's a small question. This is a small mistake. So 35 means it will come as 40. So 40 years, it has been lost because of his death, and another 5 years, it has been lost because of his disability. So you can just change this question, just a small clerical mistake in the question. So a 30-year-old male had an accident and he was completely bedridden for the next 5 years. So he died at the age of 35 years. His peers are expected to live up to 75 years. DALY in this cases. So what is the concept in this question? So what is DALY? DALY is nothing but years of life lost due to death plus years of life lived with disability. So in our question, he lost 5 years due to disability and another 40 years due to death. So his DALY can be 45 years. So what is DALY? DALY is nothing but years of life lived with a disability plus years of life lost due to death. YLD plus YLL. So what is DALY? Disability adjusted life years. DALY is nothing but disability adjusted life years. This question. So in the previous question, there was a small clerical mistake. So you just leave this question and just focus on this part of it. DALY means years of life lost due to death plus years of life lived with a disability. So now we can take a male. He is around 30 years. He is there. At the age of 30, he had an accident. So because of this accident, 5 years he was in bed. So 5 years he was in bed. Then at 35 years, he died. At 35 years, he died. Okay, 35 years he died. Normally, his peers are expected to live up to 75 years. So this is a loss of another 40 years because of death. So we have a loss of 40 years because of death and 5 years due to disability. So the total DALY will be 43 years. Next question. Calculate the odds ratio. We're going to calculate the odds ratio. So if they are asking odds ratio, what type of sum is this? It is a case control study. We're going to calculate the odds ratio. What type of sum is this? It is a case control study. So we are going to do a case control study. So we are having 250 lung cancer patients. So totally we are having 250 lung cancer patients had history of smoking and 50 lung cancer patients are non-smokers. They were compared with 300 controls, out of which only 50 were smokers. So we have cases, 300 cases totally. We have a 300 controls. So out of the 300 cases, 50 were non-smokers and 250 were smokers. Then out of the controls, 50 were smokers and 250 were non-smokers. So what is being given in the question? We are putting it in a 2x2 table. So what is the first step we have to do in a case control study calculation? We have to form a 2x2 table. So we are forming a 2x2 table. So we are forming a 2x2 table. This is the table we have to form. So in our study, we had 300 cases, 300 controls. Out of the 300 cases, 250 were smokers and 50 were non-smokers. Out of the controls, 50 were smokers and 250 were non-smokers. So what we are going to find? Odds ratio. What is the formula for odds ratio? It is nothing but it is a cross product ratio. So what is cross product ratio? A into D divided by B into C. A into D divided by B into C. So 250 into 250 divided by 50 into 50. So we have 5, so the answer is 25. Now the odds ratio is less than 1 or more than 1. Here the odds ratio is more than 1. So odds ratio, if it is more than 1, then it is a positive association. Hence, smoking is a, we can tell, smoking is risk. It is a risk factor for lung cancer. If odds ratio is more than 1, then the association is positive. Odds ratio equal to 1, no association. Odds ratio less than 1, it means negative association. So in a case control study, the measure of association is odds ratio more than 1, equal to 1, less than 1. So in our sum, we had the odds ratio of 25. So we had 25. So since odds ratio is more than 1, there is a positive association. Hence, we can tell smokers have higher odds of getting cancer compared to non-smokers. How they will write result in a case control study? They will use the word called odds. What is odds? Odds is nothing but it is like what we use in a lottery ticket or like in a game or a cricket match or in a football match. While for betting, they will use this word called odds. What are the chances? What are the chances? What is the probability? So smokers have higher odds of getting cancer higher odds of getting cancer compared to non-smokers. Next sum. So now we saw a sum based on odds ratio. Now next we have a sum. It is based on a relative risk. Calculate the strength of association in the following scenario. There are 100 smokers and 100 non-smokers. So we are having 100 smokers and 100 non-smokers. Out of the 100 smokers, 75 developed MI in 10 years. So out of the 100 smokers, 75 developed MI, 25 no MI. Then, while only 25 non-smokers developed MI. So out of the non-smokers, only 25 developed MI and 75 had no MI. So calculate relative risk of MI with smoking. So we are going to calculate the relative risk of myocardial infarction with smoking. So What is RR? RR is nothing but relative risk. So what type of study is this? It is a cohort study. So what type of study is this? It is a cohort study. So how will we go in a cohort study? It is also called as a follow-up study. Case control study, it is a retrospective study, but cohort study is called as a follow-up study or prospective study. We start in 2022 and we will go in the future towards 2030. This is a prospective study or a follow-up study. So now we are dividing them based on the exposure status and disease status. Always the disease will come in the top. Disease plus, disease minus. The exposure status will come in the left side. Exposure plus, exposure minus. Smoker plus or smoker minus. In our question, totally out of the 100 smokers, how many developed MI? So we had 100 smokers, 75 developed MI. So now study out of the 100 smokers, 75 developed MI. So we have exposed this totally 100, non-exposed is 100. Out of the 100 smokers, 75 developed MI. Then if you see here, out of the 100 non-smokers, only 25 developed MI. So the 100 non-smokers, only 25 developed MI. Now we are going to calculate relative risk. So here you should not do the problem of odds ratio. You should never cross multiply. You should remember the relative risk formula is different. So because of the fastness in the exam, if you just cross multiply and put it will be wrong. So always remember for cohort study, you have to calculate relative risk. What is the formula? It is incidence in exposed divided by incidence in non-exposed. So it is by A plus B divided by C plus D. So it is 75 by 100 divided by 25 by 100. So the answer is 3. So what answer we are getting? We are getting the answer is 3. So what is the relative risk? The relative risk is 3. So what does this relative risk of 3 means? It means smokers have 3 times higher risk of MI compared to non-smokers. Smokers have 3 times higher risk of MI than non-smokers. So the answer here is 3. Next question. We are having in our office 200 workers are there. So totally we are having 200 workers in our office. Out of this 200 workers, 56 are immunized against an infectious disease. So 56 are immunized against an infectious disease. Then one of the unimmunized worker acquires the disease today, and 28 others get that disease within 10 days. The incubation period is 2 weeks. What is SIR? So SIR is nothing but secondary attack rate. What is SIR? It is nothing but secondary attack rate. It is a special type of incidence rate. So what is secondary attack rate? Now there is a person A. We are going into a class. In this class, this person A, he is having a disease. Now he is coughing. So this class, all the people are being exposed. 200 people are being exposed. But out of the 200 people, 56 people are already immunized. So only how many people are at risk? We are having only 154 people are only at risk. So out of this 154 people, how many developed the disease within one incubation period? So the incubation period is 2 weeks. So within 10 days, within one incubation period, only 28 developed the disease. So this is called a secondary attack rate. It's called a secondary attack rate. It is a special type of incidence rate. We are dividing the number of exposed persons developing a disease who are susceptible. Number of exposed susceptible persons developing the disease following the exposure to a primary disease. So totally 28 people have developed the disease out of the 154. So 28 by 154, we are getting the answer around 20%. Here the trick is 28 are developing the disease. How many develop the disease? This you will put it rightly, but denominator, we should never put it as 200. The denominator is nothing but susceptible contacts. The denominator is what? Susceptible contacts. So here it will be 200 minus 6. So we'll get around 1. Next question. It is based on a cohort study. Now we are going to deal about a risk called as attributable risk. So what we are going to deal in this sum? Attributable risk. See, in this sum, we are having an alcoholic. An alcoholic is having 20 times increased risk of liver cancer than a non-alcoholic. So an alcoholic has 20 times increased risk of liver cancer on comparison with the non-alcoholic. Comparison with the non-alcoholic, and alcoholic has 20 times increased risk. Now they are asking the percentage of liver cancers that can be attributed to alcoholism. So what is the attributable risk? That is, what is the percentage of liver cancer that can be attributed to alcoholism? What they are meaning is, so the liver cancer can occur due to many risk factors. It can occur not only due to alcohol, liver cancer can occur due to even hepatitis virus or due to some carcinogens. So there are many factors. So out of all the liver cancers, how many percentage of liver cancers are caused only by alcoholism alone? That is called as attributable risk. For attributable risk, we have a formula. So what is the formula for attributable risk? It is nothing but incidence in exposed minus incidence in non-exposed divided by incidence in exposed into 100. So what is the formula for attributable risk? Incidence in exposed minus incidence in non-exposed divided by incidence in exposed into 100. This is the formula for the attributable risk. So attributable risk, the formula is incidence in exposed minus incidence in non-exposed divided by incidence in exposed into 100. Here what they have given in the sum. So the incidence in exposed is equal to 20 times the incidence in non-exposed. So an alcoholic has 20 times increased risk of cancer compared to a non-alcoholic. So instead of this incidence in exposed, we are substituting at 20 times. So 20 times the incidence in non-exposed. So what we are getting? So 90 by 20. So the answer will be 95%. So out of all the liver cancers that are occurring, how many percentage of liver cancers are due to alcohol alone? If you see the percentage of liver cancer that is attributed to alcohol, it is 95%. That is called as attributable risk. It tells you out of all the liver cancers, how many is attributed to alcohol alone. A study was done on association between smoking and lung cancer. There was a study on association between smoking and lung cancer. It found the attributable percentage for smoking as 80%. I think this was asked in the last November exam. So the same similar question based on the recall, it was asked in the November exam. It found the attributable risk percentage for smoking as 80%. One of the following statements false in this situation. What they are telling, smoking alone is responsible for 80% of the lung cancer cases. So they are telling smoking alone is responsible for 80% of the lung cancer cases. So smoking alone is responsible for 80% of the lung cancer cases. So we have to choose one of the statements which is false. So see, attributable risk, it is measured by dividing the difference in incidence in exposed divided by incidence in the non-exposed. That is right, it is measured by dividing the incidence in exposed by incidence in non-exposed. So attributable risk is measured by dividing the difference in incidence in exposed and incidence in non-exposed. If smoking is eliminated, 80% of the cases of cancer can be avoided. This is true. So 80% is the proportion of the people who develop the disease among the exposed. Or 80% of the lung cancer can be avoided in the general population if smoking is eliminated. So this statement is false because this denotes population attributable risk. This denotes population attributable risk. 80% of cases of lung cancer can be avoided in the general population if smoking is eliminated. It comes under population attributable risk. So for this, the formula is incidence in the population minus non-exposed by incidence in the population. I can take is the population attributable risk. So this statement deals about population attributable risk. This is right. Here there is a clerical error. So this statement is right. Actually, this statement is it is measured by dividing the difference of incidence in exposed divided by incidence in non-exposed. This statement is also right. If smoking is eliminated, 80% of lung cancer can be avoided. So 80% is the proportion of the people who develop the disease among the exposed. Next question. So this is a new type of question. So 2 drugs were used for treatment of severe COVID-19. For severe COVID-19, you have 2 drugs. Drug A and then drug B. Severe COVID-19, you have 2 drugs, drug A and drug B. So the mortality in the control drug group was 10%. So this is the new drug we are trying. Like we can take, this is the test drug which was invented by a company. This is the old drug or a normally used drug or a control drug. So if you see, the mortality in the control drug group was 10%, while the mortality with the new drug was 5%. So now we can tell the new drug, the mortality is low. So the new drug is better. We can tell the new drug is better. But what they are asking a new question, a new term. It is for INICET, they will ask many new terms. First new term is you are going to remember is absolute risk reduction. What is the new term you are going to learn here? ARR. ARR, like RRR, it is ARR. Absolute risk reduction. What is the second term you are learning? The number needed to treat. So absolute risk reduction, and the next term is the number needed to treat. So absolute risk reduction and number needed to treat. There is a formula. We will see the formula and we will come here. So what is absolute risk? Total number of events by total number of population. So total number of events divided by total number of population. Here the risk is mortality. They have given in drug A the mortality is 5%. In drug B it is 10%. So they have given in drug A 5%. So they have given mortality. What is the risk? Risk of death from this drug. Now we are going to see what is absolute risk reduction. Absolute risk reduction is nothing but absolute risk in control group minus absolute risk in treatment group. So absolute risk reduction is equal to, which is the control group? This is the control group. This is the treatment group. So absolute risk reduction is nothing but we are going to see absolute risk in control group minus absolute risk in treatment group. Absolute risk in control group minus absolute risk in treatment group. So this is called as ARR, absolute risk reduction. So absolute risk reduction, we got the answer as 5%. Next we are going to see number needed to treat. It is simple, it is nothing but 1 divided by AR. is nothing but 1 divided by AR. So it is 5%, it means 0.05. So 1 divided by 0.05 is nothing but 20. So what does this number needed to treat means? It means if you are giving a drug to 20 patients, you can save 1 patient. It is nothing but the average number of subjects who have to be treated in order to prevent 1 bad outcome. If you want to prevent 1 death, then for how many patients you have to give the drug? You have to give the drug to 20 patients. If you give the drug for 20 patients only, at least you can save 1 patient. So this is a new term you will learn: absolute risk reduction and NNT, number needed to treat. What is absolute risk reduction? It is nothing but absolute risk in control group minus absolute risk in treatment group. What is NNT? The number needed to treat. So the number needed to treat is nothing but 1 divided by ARR, 1 divided by absolute risk reduction. So answer is ARR, it is 5%, and the number needed to treat 1 by 0.05, it is 20. So next, this is also a new question which was asked in the last exam. I think in May exam it was asked. So in a superiority trial, RCT, in a randomized control trial, that is a superiority trial, the results of a study falls beyond positive margin, then the standard treatment is better than new treatment, equivalent to new treatment, inferior to new treatment, or no criteria for comparison to new treatment. So this is a relatively new question. So first I will explain you the concept of the solution. See, if you see RCT, the randomized control trials, they can be divided into superiority trials or non-inferiority trials or equivalence trials. So we have 3 types of randomized control trials: superiority, non-inferiority, and equivalence. So if you see the superiority trials, what they will do. So here we are taking a new drug for COVID-19. This is an old drug, standard treatment. Standard treatment is like we are using a drug X. Now we are using a new drug which is being found out, like remdesivir or some other new drug is. So we can do the randomized control trial in 3 ways. What they will do in superiority trial is, in superiority trial, we are taking that our new treatment is better than the old treatment or the standard treatment. So if you see here the 0, this is called as the line of no difference or line of no effect. It is like the 0, central line. It means neither he is big or nor he is big. So both are same. So from this, the center line, we will keep a margin both on the positive side and the negative side. Both on the positive side as well as in the negative side. So what we are seeing in our question? In our question, in a superiority trial, we are doing the results of a study falls beyond the plus margin. So this is the plus margin. This is the minus margin. So if it falls in the plus margin, our drug, it is falling here. So our drug is falling here. The drug is falling here. So it is falling beyond the plus margin. When it falls beyond the plus margin, our drug is superior. So the superiority trial, we always take the standard treatment is lower than the new treatment, or we can tell our new treatment is better than the standard treatment. So this is superiority trial. In non-inferiority trial, we tell that we are identifying a new drug. This new drug is on par. It is on par with the old drug, or it can be even better than the old. So it is non-inferior. In equivalence trial, both of them are the same. So they are in the same, around the 0. There is no difference between these 2 drugs. In those type of trials, they will take it as equivalence trials. So now in our question, what they had asked is, they had asked the superiority trial, results of a study falls beyond the plus margin. So the result of a study is falling beyond the plus margin. If it falls beyond the plus margin, if it is falling in this area, here it is falling in this area, then the new treatment is better. In case if they have given you a diagram and the drug B trial, it has fallen in this area, then it is inferior. The new drug is inferior, the standard treatment is better. But if it falls within this area, the central area, if it falls in the central area, then it is equivalent. Not better, nor inferior. So it is equal. So it is all about the RCT trials. Superiority trial, so the result of a study falls beyond the plus margin, then it means that our new treatment is better than standard treatment. We can also write this as standard treatment is inferior to new treatment. So we can write in this way also, we can write in this way also. So next question, this is an easy question. It was asked in the last November session. The following image depicts what type of prevention. First, identify what is this disease. See what is this disease now. You can see here. This is a leg, filariasis leg. What they are doing with this leg, they are washing. In order to prevent the infection, they are washing this filariasis leg. So already the disease has come. So already the disease has come. So what they are doing diagnosis and diagnosed. Now they are doing some washing, like it is a part of their treatment. It is a part of their treatment in order to prevent the infections, further infections. So it comes under secondary prevention. So already the disease or filariasis has come. We have to avoid the disease to going into complications. Like it may even lead to amputation, infected foot. In order to prevent the infected foot, we are washing. So it comes under secondary prevention. It comes under secondary prevention. Next, artemether plus lumefantrine is available for treatment of malaria under National Vector-Borne Disease Control Program in dosage of. So what is artemether lumefantrine dosage? It is 20 mg bar 120 mg. 20 mg bar 120 mg. I will tell you in detail here. See the patient, you are suspecting a malaria. And you can take a blood smear. Let us Plasmodium vivax or Plasmodium falciparum. For Plasmodium vivax, we will give chloroquine for 3 days and primaquine for 14 days. We are doing chloroquine for 3 days, primaquine for 14 days. So for vivax, we are giving chloroquine for 3 days and primaquine for 14 days. Next, in case if it is falciparum, or sometimes it can be even mixed infections. For falciparum, there are 2 types. One is for northeastern states, because there can be resistance there. Northeastern states, and for other states. So what is this ACT? ACT means nothing but. So the combination therapy based on artesunate derivatives. We are giving now artesunate or artemether. So the artemisinin based derivatives. We are giving artemisinin derivatives based combination therapy. This artemisinin derivatives based combination therapy is called ACT. So it can be ACT-AL or ACT-SP. So in this ACT-AL means artimeter with lumefantrine. Means what? Artimeter with lumefantrine. So in northeastern states, what we are giving? Artimeter with lumefantrine. Northeast states AL. Northeast AL. Northeast AL. Northeast AL. Then southern states like other states. Other states you can remember like southern states. SP. So mnemonic you can remember southern states or other states, SP. South or other, SP. So what is this ACT SP means? It is nothing but artesunate and sulfadoxine pyrimethamine. Sulfadoxine and pyrimethamine. So the question, what is the dosage? It is 20 mg artimeter, lumefantrine 120 mg. So in other states or southern states like this, you remember ACT, SP. ACT means artemisinin based combination therapy. S stands for sulfadoxine, P stands for pyrimethamine. So 50 mg artesunate, sulfadoxine 500, 25 pyrimethamine. These are the tablet standard doses. Then depending on the weight, 2 tablet, 3 tablet, 4 tablet they can take. The answer is 20 mg bar 120 mg. So this is the artesunate lumefantrine. We have colors. So you can see the colors here. Yellow, green, red, white. Yellow, green, red, and white. Depending on the weight. So how many tablets they have to take? 1 tablet, 2 tablet, 3 tablet, or 4 tablet. Depending on the weight. How many tablets they have to take? They have to take twice daily for 3 days. Twice daily for 3 days. And primaquine on the second day. Here they have to take these tablets BD for 3 days. Then primaquine on the second day. What is the role of primaquine? Mainly for dormants. For dormants which are living inside the liver. For vivax, this primaquine will have to be given for 14 days. For falciparum, if you give primaquine only on second day, that is only 1 day if you give it is enough because dormant. Which are in the liver, which are dormant, we have to do it. Next, all the following are true about odds ratio, except it is easy. Odds ratio, OR is odds ratio. It is also known as what ratio? A, B, C, D. It is also known as cross product ratio. So this statement is true. It is calculated in case control studies. It's true. Then odds ratio more than 1 means it is positive association. Odds ratio less than 1 means it is negative association. Odds ratio equal to 1 means it means no association. Then odds ratio can never be negative. OR can never be negative. Odds ratio can never be negative. This odds ratio it ranges only from 0 to infinity. Odds ratio ranges only from 0 to infinity. Question. We are doing a screening test for ovarian cancer. There are a total of 1,300 subjects. So there are a total of 1,300 subjects. 400 out of 500 ovarian cancer patients are reported as true positives. So totally how many cases? 1,300 subjects. We have 500 cases. 1,300 subjects. So cases, controls, or the people without the disease will be around 800. Now we are doing a screening test. In the screening test, we are seeing 400 out of 500 cancer patients are reported as true positives by the screening test. In the screening test, 400 were identified as positive by the screening test. Hence, what will be the remaining? 100 would have been identified as negative. Then 200 were reported as false positives by the screening test. So out of the 800 controls, 200 were reported as positive, and here we have 600 would have been negative. So the following statement is true regarding the screening test. So we have to form a what table? 2 cross 2 table. So we have to form a 2 cross 2 table. So this 2 cross 2 table we are forming. Totally we have 1,300. Out of this, how many are having the disease? 800 are having the disease. So 500 are having the disease and 800 are controls. So out of this, 500 are having the disease and 800 are controls. So 500 are having the disease, 800 are controls. So out of this 500, how many were identified by the screening test? 400 were identified as positive. How many were false positive? 200 were false positive. So this is what given the question. False positive is 200. They have given. See here, 200 were false positive. And then 400 out of 500 were reported as true positive. So true positive is 400. So true positive 400. False positive is 200. So total number of cases 500. So the false negative will be 100. And then the total number of controls or disease absent is 800. So true negative will be 600. So now what they are going to ask? They are asking what is sensitivity, what is specificity. You have to identify the sensitivity as well as specificity. If you know the formula for sensitivity, the formula for specificity. So what is sensitivity? Sensitivity is nothing but true positives divided by total diseased. So how many are true positives? 400. How many are totally diseased? 500. So true positive is 400. Totally diseased is 500. So we'll get the sensitivity around 80%. So sensitivity you can calculate by this. If you are having a box, if you are not able to remember, you can remember easily like this. A by A plus C. Left hand side, A by A plus C. A by A plus C. That is sensitivity. So A by A plus C is sensitivity. Then we have this specificity. Specificity is nothing but true negatives divided by total negatives or total non-diseased into 100. So how many are true negatives? 600. How many are total non-diseased? 800. So it is 75%. It is nothing but specificity is D by P plus D. So it is true negatives divided by total non-diseased. So how will you calculate specificity? This is the table. D by B plus D. D by B plus D. Specificity is D by B plus D. So we have calculated sensitivity as 80%. And specificity is 75%. So now we will come back to the sum. Sensitivity is wrong. Sensitivity is 80%. So sensitivity is wrong. Sensitivity is how many percentage? Sensitivity is 80%. In specificity, we got it as 75%. In our study, specificity is not more than sensitivity. In our study, sensitivity was more than specificity. Sensitivity 80%. So the correct option was the total number of false negative was 100. The correct option is the total number of false negative is 100. Go to the next sum. So this sum we can solve if you know a formula. Without knowing the formula, it will take your time. It will take some 5 minutes or 10 minutes. If you know the formula, you can solve it in 1 minute or 2 minutes. So a screening test was done for COPD. It has a sensitivity of 95%. What are the things they are given in the question? Sensitivity is 95%. Specificity is 95%. Then they are applying this test to the population with the prevalence of 10%. What they are asking the negative predictive value. They are asking negative predictive value. What is the post-test probability of not having the disease? After doing the test, what is his probability that he will not have the disease? That is called as the negative predictive value, post-test probability of not having the disease, negative predictive value. For the negative predictive value, we have a simple formula. If you want, we can do it like a table, like what we did in the previously, or you can apply the formula for negative predictive value. 1 minus prevalence into specificity divided by, we can write the same thing in the denominator again, and then you can change it. For 1 minus prevalence, we can change it into prevalence. For specificity, we can change into 1 minus sensitivity. So there is a formula. In order to find negative predictive value, first you have to remember the numerator. Numerator will be, since it is a negative predictive value, numerator will start as 1 minus prevalence into specificity. For positive predictive value, it will start as prevalence into sensitivity. So this is the starting point. If you remember the starting point, you can write the formula easily. For positive predictive value, since it is positive, the formula will start with prevalence and sensitivity. Negative predictive value, since it is negative, the formula will start as negatively 1 minus prevalence into specificity. Then we can substitute the same numerator in the denominator. Then we can put the addition symbol. Then the opposite of this. What is the opposite of 1 minus prevalence? This prevalence. What is the opposite of specificity? It is 1 minus sensitivity. Now on applying this formula, we are applying this formula. We are applying 1 minus prevalence into specificity divided by the same thing, 1 minus prevalence into specificity plus, we have to take opposite. What is the opposite of 1 minus prevalence? This prevalence. What is the opposite of specificity? 1 minus sensitivity. So we are getting 1 minus 0.1, 0.9 into 0.95 divided by 0.9 into 0.95 plus 0.1 into 0.05. We get it as 0.855 by 0.86, that is 99.4%. So what is the negative predictive value? 99.4%. So this was asked in the May exam. In the May exam, depending on this formula. Depending on the formula, they asked for positive predictive value. Now I have given the example with the negative predictive value. So yeah, small mnemonic. Sensitivity. What is sensitivity? Yes. The ability to detect the sick people out of the total disease. What is sensitivity? The ability to detect the sick people out of the total disease. The ability to detect the sick people out of the total disease is sensitivity. What is specificity? Specific. The ability to detect the fit people or non-diseased people out of the total non-diseased. Sensitivity, the ability to detect the sick people. Specificity, the ability to detect the fit people or non-diseased people. Positive predictive value is nothing but true positives out of the total positives. Negative predictive value, true negatives out of the total negatives. Next question. So a medical officer is there. He must calculate the expected number of antenatal case registrations in his PHC. So in the PHC, the mothers will come. So you have to calculate the number of ANC registrations. What is the information they have given? They have given crude birth rate. What is CBR? Crude birth rate. What is the crude birth rate for the year previous year? It is 40. So approved birth rate it is 40. What will be the number of expected ANC registrations for the year 2023? So based on the approved birth rate, we have to calculate. What is the another clue in the sum? PHC. So since they have not given plain area or hilly area, you can take for PHC in a plain area. What will be the population? The population will be 30,000. So what are the parameters we have? One parameter we have is crude birth rate. Second parameter we have is PHC plain area population. So based on these two parameters, we have to divide the number of ANC registrations. So now we see the formula for crude birth rate. So what is the formula for crude birth rate? Number of births live births divided by mid-year population. Usually 1,000. Crude birth rate will be given as per 1,000. So in our sum, the crude birth rate was 40. So it was 40. We have to determine the live births. So population we can take it as 30,000 since it is a PHC. So what is the number of live births? Live births is equal to 40 into 30,000 divided by 1,000. Divided as 4 is 12,200. So what is the number of live births that has happened in the PHC area during 2022? 1,200. But can you mark the answer as 1,200? No. Why? Because not every pregnancy goes into live birth. There will be a wastage in terms of abortion, stillbirth, etc. So we have to add for the wastage. Like gold wastage for pregnancy also there will be wastage in terms of abortions. So we have to add 10% for wastage. So 1,200 plus 10% for wastage. So 1,200 plus 120, 1,320. So only this answer, nearest answer, 1,003. So remember, then another one point is at any time of the year, half of this, at any time of the year, half of the estimated pregnancies must be registered with the village health nurse or the A&M or anyone in the PHC any time of the year. Suppose you are taking an inspection of the PHC on March 30. How many registered ANCs should be there? There should be at least 660. At any time of the year, at least half of the estimated pregnancies must be registered in PHC. Why it is half means because pregnancy is like a 9 month. It will take more. So if you go at any time, it is like a continuous process. They are telling at any month or any time of the year, if you check the book, at least half of the estimated pregnancy must be there in the register. Then only the PHC is working or functioning properly. This is an extra point, highly important. Next, it's another question. It was asked in the November exam. It was asked in the November INICET exam. We have. So what is this? Yeah, 28-year-old pregnant woman with 28 weeks of gestation. So we have 28-year-old pregnant woman with 28 weeks of gestation. She is coming to the PHC. What is her hemoglobin on checking? Her hemoglobin is 9.2. What will you do now? So first you have to know what is the definition for anemia. What is the definition for anemia in pregnancy? Anemia is defined as hemoglobin level of less than 11 grams per DL during pregnancy. This is related. So what is the definition for anemia during pregnancy? Hemoglobin level of less than 11 grams per dl. You can classify it as mild, moderate, severe. Mild is 10 to 11. Then moderate is 7 to 9.9. Then severe is less than 7. So mild, moderate, severe. So mild is 10 to 11. Moderate is 7 to 9.9. Severe is less than 7. So now in our question, what is the hemoglobin level? 9.2. So where does it come? 9.2 comes under moderate. So 9.2 it comes under moderate. So what is the treatment? So the treatment for both mild and moderate is nothing but instead of giving one iron and folic acid tablets, we have to give 2 IFA tablets per day. That's all. It is simple. So what is the treatment for mild and moderate anemia in pregnancy? 2 iron and folic acid tablets. So 2 tablets of IFA per day. So mild and moderate, what is the treatment? 2 tablets of IFA per day. Treatment. This treatment. So anemia, it can be prophylactic or treatment. For prophylactic only, we are giving under Anemia Mukt Bharat. Anemia Mukt Bharat. We are giving the iron and folic acid tablets 180 days during pregnancy and 180 days during lactation. 180 days during pregnancy and 180 days during lactation we are giving. For treatment, here in our sum we are going to give treatment. So in treatment we have to give 2 IFA tablets for mild and moderate anemia. They need not come even to the hospital. It can be managed at the community level, even by the health provider at the community level. They can give by doing the ANC visits. They can give. Then they will be followed up every 2 months. In case if there is less than 1 gram per deciliter increase, even after 1 month of treatment, they have to be referred to a higher center for evaluation, like first referral unit or a district hospital. There, what they will do? They will investigate them. What are the reasons why their blood hemoglobin is not increasing even after giving iron tablets? They will investigate. Then, in case whether there is a chance of poor compliance, even after giving tablet, if the health worker feels the mother is not going to take the tablet properly, then the health worker, they can refer her to a first referral unit or a district hospital. Then now our woman, she is in which trimester? In second trimester, 28 weeks. So, or she is around 28 weeks. So she is nearly in the third trimester. Okay, she is nearly in the third trimester. So into 26 weeks, she is more than 26 weeks. She is nearly in the third trimester. Suppose if she is having, like, if a woman, she is nearing the pregnancy, if she is nearing in the late pregnancy, like 32 weeks or 30 weeks, then we can refer her to the FRU. The health worker feels, then they can refer to the FRU. But for both mild and moderate anemia, what is the treatment? Only it is 2 IFA tablets. 2 IFA tablets. Then when we give this iron injection, only for severe anemia. When we are giving iron injection, only for severe anemia. What is the hemoglobin level for severe anemia? Less than 7 grams. So if in our question it has been less than 7 grams, we have to give what? IV. There are 2 types we can give. One is IV iron sucrose or FCM. FCM is nothing but IV ferric carboxymaltose. So mild and moderate anemia, only 2 iron and folic acid tablets. For severe anemia, IV iron sucrose or ferric carboxymaltose. Mild and moderate anemia can be managed by the healthcare provider in the community, like the A&M worker or the ASHA, the village health nurse, someone can manage. But for severe anemia, we need to be managed only by the medical officer. And the follow-up either monthly or depending on the advice given by the medical officer. So next question. The weight of a group of girls follow a normal standard distribution. The mean weight is 64 kg and standard deviation is 3 kg. So here they are telling the mean. What is the mean? Mean weight is 64 kg and standard deviation is 3 kg. One of the following statement is true. There is nothing but is a case of a simple normal distribution curve. So in the normal standard distribution curve, what is the area covered by mean plus or minus one standard deviation? It covers 68% or 68.3. What is the area covered by mean plus or minus two standard deviation? 0.4. So mean plus or minus 3 standard deviation will be put in 99.7. So this is for mean plus or minus 1 standard deviation. 68. For 2 standard deviation, it is 95. Then for 3 standard deviation, almost the full of the curve. Almost the full. 9.7. Full of the curve. Plus or minus 1 standard deviation. Standard deviation